Hello again. This unit is unique in that we don't particularly cover any new anatomy or physiology, but we apply what we do know to a specific patient population known as pediatric patients. We will cover the physiological and psychological needs of pediatric patients, and in class together we will discuss the most common procedures performed on them. Terms used within the specialty of pediatrics may be new to you, or you may review them. Either way, study them so you can use them appropriately. Some tricky ones include the difference between gastroschisis and omphalocele. We're going to cover these two procedures during our jigsaw unit, but note the similarities of these two conditions and then the major difference that makes one a gastroschisis and the other an omphalocele. There are some key terms used that define conditions of the intestine, such as intussusception and volvulus. These conditions can be present in the adult population as well, but they are more common in peds, which is why we cover them now instead of back in general surgery. Finally, anomalies involving the absence or closure of an orifice or tubular structure are obviously a pediatric concern, because people would not be able to develop into adulthood with major orifices or tubular structures in a closed state. Familiarize yourself with these terms, as they will definitely have to do with the surgical procedures scheduled. Pediatric surgery is a multidisciplinary field that includes the treatment of congenital anomalies, diseases, and effects of trauma. Our patient population will be wide, including everyone from the neonate through late adolescence, or approximately 18 years old. Fetal surgery, which is performed while the fetus is still inside the mother, is developing as a separate specialty of pediatric medicine. It is crucial to understand that the patient and the patient's family cannot be separated in this specialty, and both require equal consideration in communication and psychosocial care. Pages 933 to 935 in your text display images that show embryonic and fetal development week by week. During this development, there are 3 distinct cellular layers present, and each of them gives rise to a specific set of organs once development is complete. The first layer is the endoderm, and that cellular layer eventually becomes the lungs, liver, and intestines. The ectoderm has the incredibly important task of becoming the brain and spinal cord. Finally, the mesoderm becomes pretty much everything else, including the skeleton, heart, kidneys, muscles, nerves, and so on. So if you pay attention to what the endoderm and ectoderm become, you can put everything left over in the mesoderm category thereafter. Disturbances during this early developmental stage can result in defects in a structure or organ system. You already know that congenital anomalies are present at birth, but now you need to know that they can either be genetic or acquired. What that means is that some anomalies are inherited through the genealogy of the family line. There is not much that can be done to prevent those anomalies from occurring. Acquired abnormalities are a different ballgame, because they are a result of an environmental agent, which in a lot of ways can be controlled. The most vulnerable period in fetal life is the first 60 days, and that is because of the rapid cellular and tissue differentiation that occurs during that time. Examples of environmental agents are broken down into teratogens, mutagens, and the maternal diet. Teratogens are anything that exists that can cause a malformation to occur during fetal life. Examples of teratogens include alcohol, prescription or recreational drugs, and bacteria and viruses. Mutagens are anything that can cause gene mutation, and the primary example of that is exposure to radiation such as during X-rays. Gene mutation often results in retardation, skeletal deformities, or severely diminished brain development. Finally, the maternal diet can also be a source of congenital abnormalities. Lack of folic acid can cause specific spinal cord defects called neural tube defects, which include spina bifida and anencephaly. In addition, lack of protein can also cause poor fetal development. Certain infectious agents are known to be teratogenic. They can cross the placenta and cause malformations. Toxoplasmosis, for example, can cause brain underdevelopment and calcifications as well as heart defects. Toxoplasmosis can be acquired through ingestion of undercooked meat and or contact or exposure to cat feces. That's why they say pregnant women shouldn't change a cat's litter box. Rubella is a virus that produces a rash, and should a woman contract rubella during pregnancy, her fetus is at risk for cataracts, glaucoma, deafness, heart defects, and retinal defects. Cytomegalovirus is a common virus that is similar to the virus that causes mononucleosis, and if contracted by a pregnant woman, it can cause hydrocephalus and deafness in the baby. Herpes can cross the placenta and result in underdevelopment of the brain and retinal defects. Varicella, otherwise known as chickenpox, can result in muscle atrophy and mental retardation. And finally, syphilis can result in hydrocephalus, deafness, and bone defects. The body's mechanisms for maintaining balance or homeostasis in a pediatric patient are different from those in an adult in many ways. That puts our pediatric patient at a higher risk for complications during surgery. As such, the care of the pediatric patient is distinctive and therefore its own specialty. First and foremost, pediatric patients do not act like adults. Their physiological and psychological responses are different, and fear is by far the most common emotion felt by pediatric patients. The surgical technologist must be familiar with the specific conditions and needs of the patient. Caring for the psychological considerations of the patient, such as calming their fears, is only part of what we must focus our energy on. Remember, we are also very aware of their physiological needs as well. One of the biggest physiological needs the pediatric patient requires is thermoregulation. Physiological mechanisms such as shivering are absent in infants. Their surface area in relation to their actual size is disproportional. They have a larger surface area and yet their body weight is relatively low, which contributes to hypothermia. Not to mention the temperature of the environment is already cold to begin with. Pediatric patients have a thinner layer of subcutaneous fat and therefore do not have as much fat to keep them warm. Hypothermia can result in cardiac problems, apnea, and hypoglycemia. Do you remember what apnea and hypoglycemia are? Make sure you look them up in case you don't know. Environmental hyperthermia is less of a risk to pediatric patients. However, the misuse of warming devices can lead to elevated core temperatures and potential burns, so we must always be careful. Physiological hyperthermia, however, such as malignant hyperthermia, is a greater risk in pediatric patients than in adults. Things we can do to maintain normothermia include keeping infants and neonates' heads covered at all times. We want to transport them into a warm environment. Therefore, pre-warming is necessary in OR preparation. Think of some ways in which you could provide warmth and list them in your notes for discussion in class. It is critical that the core body temperature be monitored at all times. For longer procedures, esophageal and rectal probes are used to assess precise core body temperature.